Almost 500,000 patients each year develop a urinary tract infection associated with an indwelling urinary catheter. Research suggests that 50 to 70% of these infections are preventable. Across UNC hospitals, physician and nurse collaborative groups discussed the best strategies for remembering to reassess catheter needs daily, order urine cultures only when indicated, and consider alternatives to indwelling urinary catheters. Pre-programmed technological alerts were outvoted unanimously by requests to just have conversations with each other. Here now are those conversations.
Okay, that should address all the pertinent issues for this patient's care. Who should we see next?
Actually, before we move on, what are your thoughts about removing this patient's Foley catheter today? I'd like to minimize the risk for developing a Cauti.
Well, do you think we'll be able to measure accurate eyes and O's with the catheter out?
Since the patient's alert and oriented and they have family at the bedside, I can teach them how to measure their eyes and O's, and I have a flow sheet that they can document it on.
Okay, well, I'll write the order to get the catheter out and continue to measure eyes and O's. Thanks for speaking up.
Thanks.
Hello, Dr. Kuroda. I removed the Foley and the patient hasn't voided in 6 hours. The bladder scan shows 400 mL of urine.
Why don't you just go ahead and put the Foley back in?
Could be in and out cath chem now and in 4 to 6 hours instead. If every day a Foley is in, the patient has 5% increased risk of Cauti. The risk is lower in and out catheters.
I really don't want to delay his discharge.
With in and out catheters, I can get him up moving, so that may avoid reinserting Foley altogether. So if he still is in voiding 3 bladder scan and in and out cath trials, we could reinsert one then.
Okay, I think that's a good idea. Why don't you go ahead and I&O cath him every 4 to 6 hours, and then we can reassess him in 12 hours.
Thank you, doctor. Smart doctor.
Mrs. Jones seems to be resting comfortably, and we'll check on her throughout the afternoon.
These notes say that Mrs. Jones' urine has developed a bad odor. I'm concerned about a UTI. Let's send a UA and urine culture.
Do you think that's really necessary right now? She doesn't have any other symptoms of a UTI, and foul-smelling urine isn't an indication of UTI or the need for culture. She might just be one of those patients that's naturally colonized with bacteria, but doesn't have an active infection.
I hear what you're saying, but given her confusion last night and mild leukocytosis, I'm not comfortable with a wait-and-see approach.
How about we send the urinalysis right now and wait to see if the results show a need for culture. That way we don't expose her to unnecessary antibiotics.
That works for me, and that way we don't set her up for antibiotic resistance or C. diff infection.
Okay, I'll send 2 samples now. The microlab can refrigerate one, and that way if it's needed for culture later, they already have it.
Good to know. I'll follow up the UA results when they're posted.
Great.
Hey, I just got our new transfer patient settled in the bed. The Foley bag was actually on top of the bed, so I hung it on the side below the level of their bladder. But don't worry, it wasn't low enough to be touching the ground.
Great job. That will prevent the urine from flowing back into the bladder.
And causing an infection. I also cooled the tubing and secured it to the top of the bed to prevent a dependent loop for urine to collect. I'll give her a bath a little later.
Let me know if I could help. Remember to do perineal care and to clean the Foley catheter.
Got it, and I'll chart pericare and Foley care in Epic and make sure I pass off and report that we should be doing both daily.
Sounds great.